So how have we done PEEP? I started going back to when I first started. I can remember, well, first I remember we used to do PEEP by putting the expiratory tube under the water and measuring the distance and making sure that the water didn't evaporate so the PEEP would go down. But we used to increase the PEEP, and this is a suggestion in one of the papers, increase the PEEP until the cardiac output falls by 20%, then go back to the last PEEP. So people then took on the idea that you just increase the PEEP to make sure you didn't have a toxic FiO2. There was best compliance, and I'll show you a classic paper from the 70s about that. Best oxygen delivery. I worked in the ICU in the 80s where everybody had to have an intrapulmonary shunt less than 15%, which meant everybody had a pulmonary artery catheter, and everybody was on about 20 a PEEP. The minimalist Rich Albert approach of the least amount of PEEP that it takes to get the O2 sat to be 90%, and then the ARDSNet criteria of PO2 of 55 to 80. I think what it comes down to is, do you believe that you should set PEEP using an oxygenation endpoint, PaO2 or O2 sat, or do you believe you should set PEEP based on some mechanical measurement, whether that be, as Rich was talking, FRC and recruitment, stress and strain, compliance, dead space to total volume ratio. And what we're doing in both these cases is balancing the risks of PEEP, which are ventilator-induced lung injury, barotrauma, hypotension, hyperoxic lung injury if you're not using enough PEEP, and additional fluid requirements. I know there are some ARPRV aficionados in the audience, there usually are, but I think that like the high PEEP groups from the 70s, APRV is a way where people drive up the airway pressure so high that you have to fluid load the patient in order for them to tolerate the hemodynamic consequences. And while they do okay, I think they probably end up being on the ventilator longer than they have to as a consequence of that balance of risk and airway pressure.